So, for my contribution to this week's Hotcakes, I'm going to be talking about the Transform HF study. And this was a study by Mentz and colleagues, and it appeared in a January 2023 issue of JAMA. So, the research question that these authors were asking was among patients hospitalized with acute heart failure, does torsemide reduce all cause mortality compared with furosemide by at least 20% within 12 months? So you might be asking, why is this study important? Well, it turns out there is laboratory, pharmacologic, and clinical evidence to support the hypothesis that torsemide might work better than furosemide. Torsemide is thought to block the aldosterone receptor, leading to RAS inhibition, reduction in myocardial fibrosis. Torsemide also has better oral bioavailability and a longer half-life than furosemide. And there's at least one RCT out there that found that torsemide was associated with lower readmissions for heart failure at 1 year compared with furosemide. So Transform HF is sort of the long-awaited RCT intended to settle this question once and for all. So how was this study carried out? Well, this was a randomized, open-label, pragmatic comparative effectiveness trial. It was done at 60 hospitals in the United States from 2018 to 2022. 2,800 patients hospitalized with CHF were randomized to torsemide or furosemide at discharge, and the dose was determined by their treating clinicians, and they just followed up with their regular cardiologists in line with the pragmatic trial design. And the primary outcome in this study was time to death from any cause. So who were these patients? Well, the mean age was 65. A third of patients were women. 1 in 3 were Black. Patients had both chronic decompensated heart failure and acute de novo heart failure, meaning new diagnoses. They included patients with reduced and preserved ejection fractions. And what did the authors find? Well, the top line findings were that there was no difference in all-cause mortality in this study. About 26% of patients in both groups died over a median follow-up of 17 months. And you can see this really unequivocally in Figure 2, and the results were kind of consistent across subgroups. So now that I've put the basics out there, I'll stop and ask, does anybody have any questions or observations they want to share about how the trial was carried out?
I just first want to ask Paul about, Transform HF. How do you rate the trial name?
It's solid. I mean, the cardiologists are always ahead of the curve with these. So this is a nice one. So well done, team.
Yeah. Nora, I think I cut you off there, but I just had to ask Paul about the trial name. You know, he's a big trial head.
Who died a little bit inside, yeah.
No, I always spend like 1 to 2 minutes trying to figure out where the letters come from in these names. And so I did the same for this one today.
Yeah, this is, I like that they did this trial, because this is one of those things where I think we've talked about on the show before. Torsemide seems to have a much more predictable bioavailability, higher, it's like 80 to 100% oral bioavailability versus Lasix is like 10 to 100%, at least according to some like 30-year-old study. So I was excited to see this one done. Also, I haven't read it yet, but because I just noticed that this was done. But Dr. Kittleson, the great Dr. Kittleson, wrote an editorial about this. So certainly I'm going to have to check that out after this. But Rahul, what do you want to point out about this study? Because I'd love to know how much, eventually your conclusion, but any limitations or anything you wanted to shine a light on?
I mean, like you, Matt, I was also in the team torsemide camp thinking that, based on all the reasons we've discussed, torsemide I was expecting was going to have benefits that extended beyond the period of acute hospitalization. And Tony Brew actually put together a really outstanding Twitter thread on this question, kind of summarizing a lot of the data, and we'll link to it in the show notes. But this was a negative study, and publication of negative studies is really important so that we can sort of, decide if we think that a question is settled and can move on or not. And a question that often gets raised when you're talking about negative studies is, could this have been underpowered? Could this have been a false negative finding? And in my opinion, this study does not look like that. The way that a underpowered negative trial looks is when there is a difference in the point estimate, but the confidence interval just barely misses statistical significance. This was not the case. It was 26.1 versus 26.2% of patients who reached the primary outcome of all-cause mortality in each group. So really, it seems like they're drawn from the same population, no difference there. So Could there be subgroups in whom torsemide does have benefits? That's something that's possible and is sort of impossible to really detect with a pragmatic trial. So that's one of the sacrifices we make. But this is, I think, kind of how we could expect this to look if we were to roll these results out to the general population, is based on, despite all the mechanistic reasons and hypotheses for why torsemide might be better, this to me is pretty compelling evidence that for the general population at large, there's probably not a big difference.
I was going to ask about the primary endpoint. I thought the choice of mortality as an endpoint was an interesting one. Like, it's important, even if you're talking about knee pain. But
swinging for the fences with that one.
Yeah. Well, I've said it before. Nothing affects quality of life like death. But I mean, it's just for a heart failure standpoint, I feel like there's a million possible targets. Can you comment on why this one was chosen rather than sort of hospital readmissions, which I know is a hot topic, or I don't know, symptom management, or a million other things? Why death?
This is something you're kind of not used to seeing for cardiology, and in particular heart failure trials, right? We're used to seeing these composite outcomes that contain lots of badness that is patient centered. So the choice of all cause mortality has some pros and some cons. One benefit of studying all cause mortality is that there is really no adjudication required. Either somebody is dead or they are not dead. So, and it doesn't matter the cause. To determine vital status in this study, they use something called the National Death Index, which can be considered as very sensitive and specific for knowing if someone is dead. So that's a.
We've definitely talked about a study that used that before. Mm-hmm. I can't remember which one, but we have.
I mean, this did make me wonder if reporting delays might be sort of a source of bias, but I couldn't really find anything to elucidate that. So that's a benefit. A downside of studying all-cause mortality is that this is sort of the cream of the crop of impact of a treatment on an outcome. And it can be difficult to show an impact on all-cause mortality, particularly for something where the exposure and the outcome are separated in time by a large amount, where there's opportunities for other things to sort of occur that influence mortality. So it's a great outcome, particularly for an open label study. It kind of removes any concern about the effect of the lack of blinding on an outcome. Requires no adjudication, and it's sort of easy to determine, but it can be hard to show an effect.